Okay, everybody, we're going to get started. I know there's still some people out in the lobby, but I want to get us started so we have time for everyone to speak. So this is our panel discussion about different iterations of the DART model in Western Massachusetts, in Hampden, Hampshire, and Berkshire counties. So without further ado, I'm actually going to just turn it over to Michelle, our Deputy Health Commissioner for City of Northampton Department of Health and Human Services, to introduce everyone on the panel. And she will be doing a presentation with Kathy about the fundamentals of DART, and then turning it over to the others to share about their models. So with that, Michelle.
Thank you, Kiko. This has been such a joy, honestly, just looking around, getting to see people, saying hi. It's hard to not want to just spend this day socializing and catching up with everyone. But I am thrilled to start our panel discussion today because this was really the draw for us to start to discuss what's happening in Western Massachusetts, what kinds of outreach models are being attempted in all the different community landscapes that we have. There's a lot of different needs, and we're going to talk about them today. So let me introduce our panel. So we have Kathy Catugno, who is our DART coordinator. She's been with us for almost a year. We've been working together for a few years, Kathy, but I think formally in the role for about 6 months or so.
Since June.
Okay, great. And then we have Ashley Jedney, who I feel really privileged to get to work with because we've gotten to see her really grow and develop her program of the Rapid Response Team in Hampden County, which is a really close collaborating partner of ours and does tremendous amount of outreach work. And then we also have here Stephen Murray, who is a friend, a colleague, and a champion from the Berkshires, who has spent a countless amount of hours building a fire and EMS version of what's called BPOP, which is their coalition, and has created an adaptation of the model. So very exciting stuff. So I'm just going to get started here and talking a little bit about DART for those that are new. And for, just me to get a sense of the room today, who has never been to a DART training? Could you just raise your hands? Wow, that is so amazing. I anticipated there'd be maybe around, 20-30% of folks that had never been to a in-person DART training, but that's a pretty good show of hands. So welcome to the DART program and this regional collaboration of partners that get together. We learn, we celebrate our wins, we overcome our obstacles, and we troubleshoot and find our goals that are mutually set because we have a very common mission. And here you can see is our mission that is well defined, that goes on all the documentation and the pieces of work that go out there, a little bit polished and wordsmith. But I would tell you that really the mission of DART is to connect with people, to break down silos, to find a way to overcome challenges that can often seem insurmountable between systems and treatment gaps, the challenges in the landscape of Hampden, Hampshire, and Berkshire counties. We could go through every single infrastructure and be able to identify cause of potential harm or risk for people. It can be as simple as transportation and access to treatment to, feeling a sense of isolation because of anonymity concerns and not wanting to out yourself in a small community where it can be very challenging to navigate, what you need for your family or a loved one. And I want to kind of name that very intentionally. When we started this program, we had the goal of reducing lives lost by opioid overdose. And you can see here in our timeline, which is a very, very hard thing to see on these slides, but I'm happy again to share this out afterwards, that there is a lot of work that's happened between 2017 and today. And I think when the original model and the 4 communities were identified for us to try and really create a cohesive network, share these goals and values, find a way to reach people, use data-driven, evidence-based practice strategies, all of these things on paper were really well thought, but what we found was everything needed to shift, change, and pivot constantly. There wasn't one thing that stayed the same. It was almost like a daily input and feedback and refinement of needs and responses. And I honestly have our police partners, our recovery coaches, and our harm reductionists to thank because working behind an office and trying to mobilize a response as a public health professional, you feel the weight of the world and wanting to create something that people are willing to do, and they also are willing to buy in and make change around. But what we realized so quickly was that the strategies really needed to be defined as we learned how the program would be accepted, and that DART wasn't one model program. It was a program that was being adapted for each community based on their resources, based on their landscape, and based on the community's palatability, which was a big piece of the work because some communities were so happy to have DART, and other communities it took quite a while for them to understand what it meant to have a DART officer bring Narcan to your door after an overdose occurred. And there were some pivotal moments during our growth of DART. As you can see in this map, and again, I'm apologizing, the slides are a little bit hard to see throughout the space is pretty large here. We had a lot of opportunities to maybe put the brakes on and maybe make some hard stops on how many communities we could bring on, how many people that we felt like our team of a very small group, it was Cherry, myself, and Meredith really, and some support staff within the office could truly give the attention and time they needed. But we felt like if we were able to give the really critical pieces of what the role of DART was in a community, that we could trust our partners to help them adapt it, help them understand what was going to be most beneficial, and inevitably really hold those certain common goals that made the most sense for them locally. So a few of the things about DART that I have on this slide, which is probably, again, a little bit hard to read and a lot of words, were really the values, and how we shared those values was how we drove a model that could look very different from one community to another. When we did a lot of the value statements that we worked on together as a team, we really thought about what our partners would use as words to describe the program when they did public presentations or community events. We thought about what a DART participant would want to see here modeled and things that were really important to them. And then we also went on to think about what do we believe are our principal core foundational needs? And a lot of those were around data, technology, and protecting people's information so that they would trust us, because DART was really built on trust. And if people believed in our program, that they spread the word more than anything that we could ask or tell the community through media or messaging. And I just want to kind of summarize here, because I'm moving pretty quickly through some slides. The piece of DART as a living and breathing, growing program model was that we were willing to take the consideration in on what was working and what was not, and own that and make those changes sometimes. And in those moments, it can be very difficult to stop yourself on something that has gotten comfortable, familiar, and that you might honestly feel like is easier in the road ahead. But during COVID, the one pivotal moment for DART where our model shifted was when we didn't have the opportunity to do what we had been doing in the same way. And I remember there was a time at the very beginning of COVID when Trevor Dayton and I were on the phone and we were trying to figure out how we were going to support people and keep the DART program going and potentially fill gaps in systems where there were no access to support and care when everything shut down. And I remember the coaches learning technology and infrastructure and how to use Zoom. I remember getting more comfortable using our phones and texting and talking to people rather than always having our model out facing in the community to do follow-ups in person. I remember pharmacies not having Narcan access or people not transportation to get it, and police department partners who were, there on the front lines during COVID doing this work, going above and beyond to make accommodations to get people services they needed, and realizing that there was nothing that we couldn't do if we were willing to be flexible and change and evolve and grow. And I don't think there is a model that you can hold to a certain standard and over time in this work that is gonna never fail are never make mistakes or never need to reassess. And I count on everyone here in the room, and I count on our partners and our collaborators to give us that feedback and let us do the work to make that change. So I'm so excited to have Kathy speak a few words here about, some of the pieces of DART that make us so important in the role of public health, working with public safety. But I think in sense, to give you the overall idea of what DART is a group of people that have come together to create an innovative infrastructure that looks to try and meet people's needs as they grow, evolve, and change, and truly create an opportunity to serve people where they're at, reduce stigma, overcome barriers of isolation, and look to bring systems change with many different kinds of change makers. That could be employers, that could be treatment providers, that could even be, your local library, and how to be more friendly and helping support people for warming needs and overdose risks and installing nalox boxes. So, there really is a hard ask when you're trying to present this in a succinct way. But I think that the biggest thing DART is it's a group of people who really care and are looking for opportunities to do things differently and try and see a future ahead. So, Kathy, I'm going to give you this next slide.
Good morning. As Michelle had said, I came to DART about 6 months ago, but prior to that, I actually worked in Westfield, and I was one of the key people to actually bring DART to our Westfield community. And with that collaboration, at that time, I truly believed that we needed our system to change and we needed to provide services to our community in large, but also in particular to our substance use community. And by coming there, one of my biggest things that I was looking at, because of history in my family, I wanted things to be rooted in harm reduction. We needed to make change in substance use and how we looked at that. And I wanted us to be able to provide safety plans, the connection with those people, meeting where they're at. It wasn't about telling them that they had to go to detox or they had to be in treatment or that you had to change. It was about learning how we could help them, not tell them what we were going to do for them. And so that was when I had this opportunity to come to DART. I knew that I am looking to make a system-wide change in how we address our communities on health equity, disparity, across the board. And we all know that most people that are in substance use, like you heard earlier this morning, have underlying mental health conditions, and we don't always address those. I also believed that there were supplies that we could offer, and I truly believe that we are going to save a life by offering Narcan. So one of our big things with our DART program is that we provide through federal funding that we can provide Narcan to everybody and anybody out in the community. We will do the training. We also, if it's a person of substance use, we will, our partners can get them Narcan. We get Narcan to family members. We get to train community resources and businesses on how to supply and use Narcan. We have nalox boxes. It is one of our largest campaigns currently. And again, through federal funding, we can supply communities with nalox boxes for libraries, businesses, so that you in the community can save a life. And if we can do that, then we're going to make a system change. I also believe in our police departments, and I love that partnership, and I also believe that they really want to see change happen. They have learned over the years that punishment and arrest is not the answer. It's bigger than that, and this, unfortunately, disease is not going to go away. And how are we going to meet our communities? And every community is different. You know, the DART program overall has a structure, but we also work with those communities on how to meet those needs in the community. And I think that that's really important. We also share resources. So again, if you are looking for something, call me. I actually have business cards with me today, so if anybody would like one, I certainly can do that. I think that the system change and the knowledge is where DART's philosophy is. And if we can do that, we will make a difference in Western Massachusetts. And that's what we need to do. That's why we collaborate together across the counties. And it is imperative that we keep moving forward. And so that's my story.
We had a few more statements here, but again, this email is going to be sent out for you. And I encourage you in any part of this, by the way, any of the materials that come out to you today, if you'd like to use them, have them adapted for your own community presentation, feel free to use them. That is all good for us. Okay, so Ashley.
Thank you. Good morning, everyone. My name is Ashley Dedney. I work at the Hampden County Sheriff's Department. I am the program coordinator for our post-overdose outreach team, and I also coordinate the Hampden County Addiction Task Force with the Hampden District Attorney's Office. So just for slide purposes, I'm gonna walk around. So the Hampden County Addiction Task Force is a collaboration between the Hampden County Sheriff's Department, the Hampden District Attorney's Office, as well as Bay State Medical Center and Mercy Medical Center. So the Hampden County Addiction Task Force brings community organizations, law enforcement, schools, community members together to address substance use disorder, overdose, and prevention. We have monthly coalition meetings where we all come together and just discuss what's happening in our communities, what can we do better, where are the barriers, what are we seeing. So in 2020, the Hampden County Sheriff's Department received funding, COSAP funding from the Department of Justice. And with this funding, we were able to fund our post-overdose outreach team. So our post-overdose outreach team consists of myself as the program coordinator. We have Harvey McNulty, who is our recovery coach. Harvey, you want to wave? We have John Jazak, who is one of our deputies. And then we have James Barron, who is one of our other deputies. So what we do is we provide post-overdose outreach to individuals in Hampden County 24 to 72 hours post an overdose occurrence. And then we will also follow up on individuals who are considered at risk. So we work very closely with law enforcement in Hampden County and with the police departments within Hampden County. So we utilize the Critical Incident Management System, also known as SIMS, which you guys, I know some of you are familiar with, and a lot of you will learn more about that later today. So in this database, police departments are able to share information regarding non-fatal overdoses, fatal overdoses, at-risk referrals, as well as behavioral health events. I monitor the database, and once we receive this information, our team will go to do our post-overdose outreach. So what does this look like? So our outreach deputy, our recovery coach, and then we work very closely with Tapestry Health, which for the harm reduction side of things, we will go to the individual's residence, we will do a door knock and try to connect these individuals to services. So every conversation is different at the door with individuals. I know Kathy mentioned it. It's kind of, some individuals will be open to detox. Some individuals will be open to MAT. Some individuals don't want to talk at all. So we're not there to tell people what to do with their recovery. We're there to listen and talk to them and have a conversation and see how we can help. Can we just connect them to mental health services? Can we connect them to health insurance? Can we connect them to employment team? So there's many different things that we can do when we're at the door with the individuals. We also provide Narcan when we're at the door, and we'll also provide packets of resources. We have them in English and Spanish, so that's just a wide variety of substance use resources and a wide range of other resources as well. So again, like I said, supporting all individuals in the pathways of recovery. We're not there to tell individuals what to do. We're there just to talk with them and see how we can help. So our original outreach will be at the residence, and then we will follow up further. We'll go back to the residence. If we don't make contact, we'll go once or twice and just try to see if we can reach the person. We will also try to follow up via phone with these individuals if we do have a phone number provided. On the other side of that, a lot of times phone numbers, aren't in service. They're not working. We can't get a hold of individuals. So for us, we always go to the residence originally, first thing. So if we do connect with an individual, Harvey will continue to follow up with them, see where they're at, how we can help, and how we can go from there. But yeah, that was a brief overview of what we do. Like I said, please feel free to reach out. We also have community referrals as well. So individuals in the community can refer individuals to us. So it doesn't always have to come from law enforcement. If there's someone, family members, friends that know someone that is suffering with substance use, we are here. And as well, we're here as a support for family and friends so we can connect individuals, to learn to cope. I know Peter and Magda are here and they'll speak later about learn to cope. Kathy, yeah, thank you. So any way we can help, we're there to talk to the family, the friend, the individual, and just address this. As Kathy said, it's about everyone collaborating together and coming together. This is an issue that we all have to work together at. So all of us coming together and working towards it is all we can do. So, thank you.
Hey, that worked out. Hi, good morning, everyone. My name is Stephen Murray. I'm really happy to be here with you, see a lot of friends here. I've been a DART consultant for the last 2.5 years. I now work at Boston Medical Center, where I oversee our post-overdose outreach research. So I have learned a lot about the sort of programs that are going on around the state. It's always nice to be back where I started. I was a paramedic in Western Mass in Berkshire County for almost a decade, and also worked as a firefighter earlier on in that. And I'm a person in long-term recovery and overdose survivor. And so this work is really deeply meaningful for me. So in Berkshire County, what happened was we started in 2019 with a community-driven process, and it was a room full of public health people, and law enforcement wasn't really involved in those early conversations, but I was there because I was like the guy in recovery. And so we started with this fire EMS model. And what we found was that it was really not easy to do for a few reasons. So for the first part of it, COVID started and EMS got totally overloaded. We didn't have the sort of readiness that we needed to really launch as a project. And we found that along the way, there's a reason why 86% of post-overdose programs in Massachusetts are police-driven. It's because there's a different sort of level of data requirement around privacy and around HIPAA. It makes it really difficult for EMS agencies to share data with other partners. So you hear a lot from these other groups about how you're partnered with recovery coaches or you're partnered with harm reductionists. It's really not that simple in the EMS world. And so we've been working to overcome some of these hurdles. We established a relationship very early on with the DART program. A lot of funding came through. And so it's been a really great relationship. So we did a couple of things. So as we were trying to figure out how to get this program going, we did a couple of things to build readiness around the county. So when we started, there was about 30% of fire departments and 40% of police departments were carrying Narcan. We've expanded that a lot. It's over 70% for both now. That Narcan was all supplied through DART, through the COSAP grant. We also started the first Narcan Leave Behind program in Western Mass early on when it first was approved. And we were leaving behind Narcan at the scenes of overdose, sort of I call it pre-post overdose outreach. It's the first attempt at leaving something behind to establish a meaningful connection. I'm going to give a talk later this afternoon about what this process looks like. So I'm not going to really go over it too much here, but it's sort of a multi-step process where you have to get some different OKs throughout the system. You need to have your public health director involved and either the mayor or town manager, and then your hospital affiliate medical director. So I'm going to help people walk through this process if you're interested. I think that there's room for both police and EMS to be doing this work even in the same place. And one of the reasons for that is that the future for EMS-based post-overdose work is in the mobile integrated health field, where we're seeing the ability for these programs to scale up and provide a lot of hospital-level services in the home for patients. So directly partnering finally with harm reduction organizations, and then doing things like wound care, starting antibiotics for wounds in the home if the person doesn't want to go to the hospital, and even starting Suboxone in the field. So there's a lot of sort of room for growth under the EMS model. And then the other thing is that we, like DART, have quickly decided that we need to offer this program for all people who use substances. And so we're also doing work around stimulant use. And so there are calls where law enforcement may not be involved. And so it's another way to sort of grab other people who would be in need of services. I also want to shout out to Andy, who works for the BRPC in Berkshire County, who's my partner in crime in this project. And we actually finally got our approvals. We trained everybody and they are really starting finally. So it's a big relief because this has been a 3-year project. And thanks to Dart for all the support.
We wanted to be able to take some questions from the audience so that we could answer any burning thoughts, especially for all those new folks here in the room that want to understand, what is all of this about today? Why are we here? What is the goal? And the goal really is to help get you the information on what we're doing here in Western Mass, but also how we can connect with you, how we can support you, concerns you have for your community right now. And again, in the afternoon, we're going to be having a more detailed Dart 101, so we can get into any of the fundamentals around Dart more specifically. And we have the Academy upcoming, but this is an opportunity to talk to our panelists and find out what some of the similarities, differences, assets are. And I encourage anyone to raise a hand. Be brave. Ask a question.
What are your programs doing for the schools around both Hampden, Berkshire County, both with DART and the task force? What are you doing for kids within school, or I guess graduates or minors, really?
That's a phenomenal question. Some of the program regulations around how we design this work come from our funders. And in many cases, we're funded for adults and work with people that are generally 18 years old and older. But as a mom of, a 9-year-old and a going on 20-year-old, during the work developing this program, I found it was so amazing that when you offer opportunities to support the family household and the infrastructure, you're also modeling new opportunities for youth engagement. So it is a little bit limiting for us on when we do the outreach when an incident occurs, or if we've been given a referral of someone that is having a substance use risk. Often it is an adult in the home that we're there to support, but we really think a lot about trauma-informed practices and how we can shore up that household for the youth that are definitely impacted. And nothing speaks more to that, I think, than when we experience grief and loss. And that happens, and it has happened for our DART team members when they have responded to help family systems where an unfortunate loss has occurred of sometimes a parent, and there's grandparents often raising grandchildren. So households are really complicated. It depends where you live. It depends on your school system. And sometimes I think for DART, there's a definite bridge where the DART officers hold key resource opportunities that they can share with the schools, and also our school nurses has been a real evolving partner and relationship development. And I know Kathy can speak to that a little bit.
A couple things that DART has done and will continue to do is we do provide training to staff of school systems. I can tell you in particular, we did Westfield and provided Narcan training for all of their nurses, and we will do a follow-up on a yearly basis with them, and also had staff that came to that. Some of the youth piece does fall under the prevention coalitions. For us, we work very closely hand in hand, but in those other communities, they also have realized the need for Narcan training for youth and the school systems. And again, it is a touchy area. It's an area that's starting to actually grow with questions and concerns, which I'm happy to see, because our youth have a lot to offer us, and we need to support them across the board. And so I'm excited to see that continue to grow.
Yeah, so our program being fairly new, hopefully, with the Hampden County Addiction Task Force, as you know, we're the Youth Advisory Board with the Hampden District Attorney's Office. So as part of HCAT, we put on events such as, there was an event last night in Westfield, preventing accidental overdose, with the youth students spoke, about their experiences and what they see on a day-to-day basis within the schools. But as far as our post-overdose outreach team, it's geared towards adults. But again, hopefully come the future, we can get more education out there. We can start going to, middle schools, elementary schools, and just get the word out there to these students, because a lot of times too, these kids will have their parents, that suffer from substance use disorder, and just having the education out there. So definitely just on our end, just talking about it more and providing more education is hopefully something that we can do and expand in the future on our side.
Stephen, did you want to comment, or shall I go to another question?
I'm just going to briefly say that I think that one of the sort of natural parts about post-overdose work is that it's very reactive in nature. And so like we, in a lot of ways, wait for an overdose event to occur and then the follow-up happens. And so in the case of an EMS-based model, we do respond to overdoses in like teens and young adults. And so I think that we would be open to like responding to work with kids with parental permission. I don't think we have any specific funding restriction from our grant, which is the OD2A grant. So we are kind of looking into like ways that we can support younger people, especially as we see fentanyl work its way into pressed pills and cocaine. We're going to be seeing more and more youth overdoses. So I think that's definitely a good question.
Yeah, thank you for mentioning
One more
that.
point I just wanted to mention is advocacy and policy change. A lot of where we struggle in systems and making systems change is things are very parted out for youth and for adults. And I think that's a role that we take very seriously and are actually quite active right now thinking about naloxone box placement in schools, youth having the right to carry Narcan on school property, and lots of other pieces around DCF and other systems of care, which I know we have some DCF folks with us here today who are champions and warriors for family support. So often our coordinators will join in meetings and coordinating of different kinds of methodologies that we can co-learn and support each other to try and create more infrastructure around how to support the whole family that often touches youth.
Hi, I just wanted to ask Ashley, I saw on your slides that there's a warrant check before you guys go in. So if you could just talk about what that looks like and if it has any impact on kind of the responses or people's willingness to participate, that'd be great.
Yeah, so as far as the warrant checks, it doesn't necessarily even we do it for safety purposes. So we're going into communities in Springfield, we're going to communities in Holyoke, we're going in communities all over Hampden County, it doesn't matter. So we do the warrant checks for safety purposes. As far as like if an individual has a warrant, we don't act on the warrant. So our outreach deputies would never, oh, they have a warrant, let's go pick them up on this warrant. We wouldn't do that. We're not there for the law enforcement side of things. We're there for the community outreach side of things. So as far as the warrant checking it's more so for safety procedures on our end and kind of like just letting the outreach deputies kind of know what they're going into situation wise. If there was any sort of like law enforcement and criminal activity that we needed to address, it wouldn't be anything related to our team or on our end. So we're not there for that aspect.
This is where I get my steps in.
The EMS model that's affiliated with Boston Medical Center, is that just in Berkshire County, or are you coming closer to this area?
So to help you draw the distinction, so I was a paramedic in Western Mass when the program started, and I retired from EMS about a year ago. So I now work at Boston Medical Center, so I kind of wear two different hats. I'm still involved in sort of the implementation of this program, but we are kind of looking at the healing community study money as a way to sort of fund for the next year, which is through BMC. So there are a lot of connections there. I'm available through DART for TA on EMS-based programs. So if you're looking to bring one to somewhere here, just get in touch with Michelle and or someone from the DART team, and we'll be able to help you out with figuring out how to implement in your own community.
And I would add that, Stephen, you deserve a lot of credit because you have accomplished milestones with EMS and approvals that had not been accomplished yet across the state. And it is a really important piece of the information that I think we all could share as I'm walking around, just even having brief conversations with folks. We're all at capacity. COVID, technically is behind us, they say, but everyone is still experiencing infrastructure and workforce challenges. The more hands on deck, and the more hands on deck that have the opportunity to do this work with us is better. And many of our smaller communities that have DART programs, they have fire and EMS champions that have come to the trainings, support them regularly. Oftentimes we'll provide each other Narcan in gaps and needs. So we really were thinking about this more succinctly before COVID, but we will be returning to give it as more of an a la carte opportunity or, menu of opportunity for communities to be able to say, our fire and EMS right now have, a better staffing infrastructure. Maybe they can carry the load or share some of that weight. And I think the idea that those two agencies within a community aren't working together already kind of makes, no sense. So I think bringing them together, understanding what each other are doing, and then sharing information is always more valuable.